2, the topic's chronic disease. You know, health is no accident, and neither is chronic disease. But many of you are probably on a collision course with chronic disease, and a lot of it is because you're in this line. You may be way at this end, but you're waiting for the pills and surgery. There's not nearly enough people wanting to get into this line. And the whole point of all my talks is going to be to try to drive you into this line, convince you it is not an option to stay over here. Okay, but I'm going to teach you all about this line, and I'm going to teach you about chronic disease. And to review, the last talk, we sort of introduced the concept of chronic disease, 3 major aspects that drive 60% of what kills us, which is cardiovascular disease, primarily heart attack and stroke, brought on by things like blood pressure, which is multifactorial, and we'll discuss that at some time. I'm not going to make it a big part of today, but I'm going to point out how much it affects cardiovascular risk outcomes. Small, dense cholesterol particles, these little particles that are getting oxidized and mashing into the wall of the artery, causing clogging, eventually rupture, plaques that block off arteries, kill stuff downstream, and make you not work anymore. Okay? Coat those babies with some sugar, we see that diabetes makes everything worse, massively increased risks of all chronic disease. Lifestyle definitely is your number one preventer of type 2 diabetes, which comes from insulin resistance. And number 3, inflammation. If we inflame the walls of those arteries, guess what? They get leaky, more cholesterol gets through, more clogging, stiffer vessels, higher blood pressure, yada, yada, yada. It's this vicious cycle. So, we're going to talk about those small, dense cholesterol particles because it's such a cornerstone of what I spend a lot of decision making in my practice doing, which is 2 questions. Aspirin, and that answer's evolved a lot since I got out of medical school, and statins. That's the word collectively for the drugs that lower cholesterol and at the same time also stabilize plaques. So when I'm not a lipidologist, but I'm working on it. And I'm going to tell you that opinions about this subject vary widely. I take the approach of an integrative doctor, one who looks at holistic ways to manage health as the first choice and medications as a second choice, a blended model. I don't run to the tool bag of pills and surgery the second I see a patient. Okay, so we've got small dense cholesterol particles, diabetes and glycation, makes them stickier, vessel wall inflammation, all the things that cause those 3 things, and we're going to focus right now primarily on the particles, lipidology. These things are mostly genetically driven, though you can take a pretty decent genome and create a pretty crappy lipid panel with lifestyle. I've seen that because I've seen people reverse it. But in a lot of people, like myself, I've had dyslipidemia my entire life. So, the question that I'm going to try to answer or teach you how I answer it is, how do I decide whether you're going on a statin or whether you're not? And we're going to start with the normal surveillance that everybody gets. So I think the standards are that, like when you're 20, you're supposed to find out what your lipid panel looks like. And if you have a bad lipid panel or an abnormal one, we call that dyslipidemia. And to share what that is, I actually the definitions evolved over time since I've been in medicine, which were over 30 years now. But what we used to say was dyslipidemia, and what Quest Labs still demonstrates as dyslipidemia, is if your total, so this is the target. Total cholesterol should be less than 200. HDL, or the protective cholesterol, should be greater than 40. LDL, these small dense particles that clog the vessels, should be less than 100. And the ratio, the coronary risk ratio, which is your total divided by your HDL, should be less than 5. And your triglycerides should be less than 150. Now, if you don't meet all of those criteria, technically you have dyslipidemia. So the question is, if you have dyslipidemia, what's the next step? Now, a long time ago, it was cholesterol medicine, if you met any of those, which I can tell you a lot of us do. I've never not had dyslipidemia. Now, the point is, we're trying to stop this is a very crude drawing of a blood vessel. These are the intima, or the endothelium, a single cell lining that can become inflamed and leaky. This is the space in between the intima media thickness, and in the carotid artery, which we measure in my practice, we call it the CIMT, carotid intima media thickness. It's reflective of how much of these small LDL particles you've wedged through the wall of the blood vessel. These blue ones are there to represent HDL, which sort of protects the good cops. The purple ones, the LDL bad cops, and the little red circles are red blood cells. Okay, so we're trying to prevent that from occurring in all of us. Well, back in the day, take a statin. You've got a bad cholesterol panel. Your LDL is too high. But then it turns out there are side effects to statins, and when we started looking at scientific evidence, they weren't really reducing mortality when we just gave them to people to control their cholesterol. And so they've developed other strategies to help decide. And a lot of them are these decision-making risk predictors, okay? And this one I share with you because it came to me recently through Medscape. It's the current recommendations from the American Heart Association for primary care physicians like myself, I guess I'm one of those now, on how we should follow the algorithms for deciding whether or not to treat with a statin when a patient's cholesterol is not perfect. By the way, this is probably going to run over 30 minutes. This is my second run at it, and it's a lot to cover, but for cohesiveness, I don't want to break it into 2 modules. Stick with me. You want to understand this stuff, especially if you're my patient and we're trying to share in decision making. Okay, so risk prediction models, the Ascvd risk calculator, they call it the pooled cohort risk. It predicts the risk of you having an atherosclerotic cardiovascular disease event, that's a heart attack or a stroke, in the next 10 years. Now, this particular one's pretty simple. It includes everything that all of the models that I use include. But it doesn't really have much in the way of add-ons, and it has a pretty high predictive risk. Bothers me a little bit because we'll go through the guidelines here, okay? This particular calculator predicts risk pretty high. So here's the guidelines, okay? Now, peer-reviewed, validated, online calculator. You can look this up and plug yourself in if you know your numbers. It's for use for people that don't already have cardiovascular disease, and it's used to recommend statin therapy in those whose risk of a heart attack or stroke in the next 10 years is greater than 7.5% in the event that you don't meet other criteria, which is A, you somehow have a cholesterol an LDL less than 70, which nobody has an LDL less than 70. Very few people, okay? You have an LDL greater than 189, in which case you don't go into the equation, you just treat. Now, I don't follow that algorithm, but we'll talk about that. You have diabetes, in which case you treat if your LDL's not below 70. And of course, all those that have had established cardiovascular events are on statins, and I'm 100% behind that because secondary prevention, which is protecting you from another heart attack or stroke, statins have proven significant reduction in mortality. And in my opinion, it's not because they lower the LDL cholesterol and slow down the progression of future disease, but they stabilize those plaques so you're less likely to rupture one and thrombose it, fill it with clot, block it off, and kill everything downstream. Okay? So, again, current guidelines, treatment with statins, individuals where you already have had heart attack or stroke, individuals with primary elevations of LDA greater than 190, and that's not a huge portion of the population. Individuals 40 to 75 years of age with diabetes, totally controllable unless you have type 1, and an LDL 70 to 189, the vast majority of the population without heart attack and stroke, and individuals without cardiovascular disease or diabetes, 40 to 75 years of age, LDL 70 to 189, and a 10-year risk greater than 7.5%. All right, so what's my problem with this? Well, we'll just start with me. Okay, so I've got a recent set of labs here. These were right after COVID. They're not my best labs, but there's my cholesterol panel. We can see that my total is greater than 200 at 232. My HDL is pretty robust at 68. I take niacin, that helps. May not make me live longer, but it makes me feel better. My triglycerides are good, 83, below 100, well below the normal or the danger range of 150. My coronary risk ratio is 3.4. That's below our stringent target of 3.5 and below the normal of 5. So let's plug those in. Here we go. I will tell you, whoops, that's the next one. I will tell you that I run typically a blood pressure of around 105 systolic. I'm 57 years old. I am not taking blood pressure medicine. I don't have diabetes. I don't smoke. I am Caucasian. My total cholesterol was 232 and my HDL was 68. So with this crude thing, not smoking, not having diabetes, not on blood pressure medicine, a low blood pressure, 57, with those cholesterols, they calculate my risk at 4.3%, and I guess I'm pretty close to perfect because 10-year risk, similar patient with optimal risk factors. But remember, I got dyslipidemia. I mean, my LDL was what, 100 and... what the heck? Short memory, huh? My LDL was 145, okay? Lifelong dyslipidemia, but it doesn't look like I'm going to have a heart attack right away. All right, well, first thing I want to point out is what happens as we age. Now, if you want to drive up risk, go from female to male, increase your age. None of those variables you can't control. Increase your blood pressure. Go with the same blood pressure, but get on a blood pressure medicine. Your risk still goes up. Medicine doesn't cure your risk. It might lower it a little. Being healthy cures your risk. Give yourself diabetes, and if you really want to see it go up, smoke. Here we go. What if I smoked? Let's just see. All right, I got these great looking numbers up, doubled it basically, 7.6%. Okay, but we're not going to smoke, so let's get that back to normal. All right, so now here's what I want to point out. I'm 60 years old. I have a normal cholesterol panel, okay, which we said was a total cholesterol less than 200, got it, an LDL cholesterol of greater than 40, There's 41, got it. And a normal systolic blood pressure, and we've lowered that now down to 120 from 140. More medicine that way, of course. Not saying you shouldn't treat your blood pressure, just pointing out a fact. All right, let's calculate. Bam, 8.9%. So 60, no dyslipidemia, no high blood pressure, but I'm a male. Time for a statin. So the indication for a statin, according to what they're telling us to use, is being male, 60, and having a hole in your face called a mouth, I guess, because there ain't nobody running around with cholesterols less than 70 organically unless they're freaks of nature. And normal blood pressure, unless you're exceedingly low like mine, because I train and I'm fit and I'm not overweight, and all those things are associated with low blood pressure, as well as I probably haven't developed much stiffening of the arteries, as you will understand as you learn more about me, as well as I don't have much genetic risk for hypertension. My family runs low blood pressure, and there are evil humors in some of you that probably are not controllable by lifestyle that make that risk factor greater. Maybe you'll get lucky and have the good cholesterol genetics. All right, so there's my point there. We can play around with other things like I talked to you. You want to drive up risk? Let's just go to 140 systolic. 8.9, now what happens? All right. Here we go. 11.5. You know, that's mild hypertension. Now, what happens? So, okay, well, we'll put you on some blood pressure medicine. What if you're 140 and that's on medicine? Whoops, got to calculate. 13. All right, let's get some diabetes in there. %. Sugar, not good. We're going to talk about sugar. Okay, so that's the pooled cohort risk. It has a high predictor. It says you're likely to have a heart attack, more so than some of the others. The recommendations, according to the American Heart Association, are to treat if your risk is over 7.5% and you're otherwise normal, meaning your cholesterol LDL is between 79 and 189. Don't know if I'm on board with that, but we'll talk. All right, well, there's some other calculators. Here I am in the MESA score. Now, the MESA allows the addition of an extra piece of information that we'll talk about, the coronary artery calcification score. Mine was 6, which is basically 0. 0 to 10 means there's almost no chance you have vascular disease, and my angiogram that I did supported that. I'm male, I don't have diabetes, I don't smoke, no family history of heart attack. There's my cholesterol numbers. My blood pressure this morning was 103. I'll put in my average of 105. And then let's see, it says, with this risk factor, including the coronary calcium score, my risk of a heart attack or stroke is 3.5%. Okay, now, if I take out this and recalculate, oh, I'm sorry, it was 2.8%. It hadn't calculated yet. All right, let me go back. 6, I'm sorry, guys. 10-year risk. Wait, computer's slow over here, I guess. All right, so 2.8%, including the coronary artery calcium. Now, when we take that out, I don't have a coronary artery calcium score. It'll calculate me at 3.5%. 3.3. Did not factor in their coronary calcium score. My risk is 3.3%. Okay, so coronary calcium score is another dimension we can look at in addition to additional risk surveillance predictors, okay? We're going to talk a little more about coronary artery calcium score and CT angiogram in a minute. But what I will tell you is that if you have coronary artery disease and coronary artery calcium is reflective of that, your risk will go up considerably. So let's say we put in a figure like 150, which would predict a moderate chance that you have mild to moderate blockages somewhere in your heart tree, okay? Now let's recalculate with all the other aspects that I have. It upclassified me to a 6.4% chance because we know I already have some cardiovascular disease, right? Probably that guy ought to be on an aspirin. All right, well, Joy, I see my camera shut off. As I was saying, the guy with all the demographics I have, but a coronary artery calcium score of 150, he at least ought to be on an aspirin. And, you know, you might think about starting a statin because you're making disease, even though your risk prediction is still below 7.5%. All right, so we're going to move along to another calculator, the Framingham Score. It's got my numbers in it. Age 57, male, non-smoker, total HDL, systolic blood pressure, not on blood, oh, that's on blood pressure medicine, 6.8%. Now, not on blood pressure medicine, 5.4%. So I'm still less than 7.5. Notice the average person my age, Caucasian, 10-year risk would be 13%. So that's good news. I'm doing better than the average despite my bad cholesterol panel. Now, there's another, that was called the Framingham Score, and this is the Reynolds Risk. And Reynolds Risk includes inflammation. Now, these labs that I took were back right after the COVID, and that was the highest CRP I've ever had, although it was normal, 0.6. So I put in age, don't smoke, systolic blood pressure, we don't want that, 140. I was showing you what it does there. Systolic blood pressure, 105. Cholesterol, 232, HDL, 68. No mother or father heart attack before or stroke before 60. Calculate 10-year risk with that low inflammatory marker. And it says 3%. And then I think I was in my previous lecture that didn't record. God, I love this. When I put in the 140 blood pressure, it doubles my risk to 6%. So blood pressure is one of those things that I wanted to point out. We're not going to dig in deep, but the whole process of atherosclerosis makes your blood pressure go up because the arteries get stiff. So the pump pumps into stiff pipes, the pressure goes up. But there's evil humors that cause blood pressure also, okay? So some of you, I have genetically pretty low blood pressure. Nobody in my family's ever had problems with high blood pressure other than my grandma on my dad's side. Some people have evil humors. There's other things, the way the kidneys work and electrolyte balances and other things that cause high blood pressure. But the stiffening of the pipes, this whole process we're talking about, it contributes. All right, so we got through the risk algorithms, and basically what they say is, hey, look, more or less, if you're going to follow the disease model recommendations, if you're a normal person with an LDL between 70 and 189, and you have blood pressure out of control, or diabetes, or you smoke, or some of these other things, your inflammatory markers are high, and your risk is getting driven above 7.5% of having a heart attack or a stroke in the next 10 years, we think you should take a statin. Now keep in mind, these prediction models are done on America, okay? A population of sedentary, rotten diet, overweight people. And if you're following the lifestyle I'm going to teach you, whatever your number comes out in this, it's actually really lower. I mean, I can't validate that, but don't outsmart your common sense. I mean, if you're exercising, you're eating right, the equation doesn't count for that, okay? So you may have numbers that aren't as good as they might be because of genetics, but you're doing things that the rest of the population isn't doing that can help. So I think we got to dig deeper, right? So what's the additional strategies, okay? We've got the risk prediction algorithms. Well, another thing we can do is we can fractionate your cholesterol panel. And I'll show you what mine looks like because it's horrid. So I don't think I had it up. I'll pull it up real quickly. My VAP color panel. Here you go. Okay, so it turns out that there's really bad small LDLs and not so bad. And so this looks more at everything. Now this was a while back, 2015. My total LDL particle number was in the moderate range. So not horrid, but not great. But I got all the bad actors. I got tons of little tiny ones greater than 217. I got a lot of medium-sized ones, also not great. I wish I had the big fluffy ones, 379, greater than 271. And then my HDL, these protective molecules, not so great. You want to be above 9,000. And even though I have a high HDL, apparently I don't got the big fluffy ones. So, but I don't have heart disease according to my coronary artery calcium score and CT angiogram. We'll talk about other things that I've measured that are good. Here's a big one. There are protein markers that we can look at. And the Lp(a) is one that is not really addressed much in modern medicine. I saw a Medscape article about a year ago that said Lp(a) is now the time. Well, I've been looking at it for 5 years because Synagenics trains me well. One of the reasons they don't look at it is because nothing fixes it. Actually, it's not modifiable by lifestyle, and we don't know of any drugs that fix it. But when we find one, we'll be measuring it on everybody, I promise. About 20% of people are high, above 125. I'm undetectable. It doubles your risk of heart attack and stroke regardless of what your other parameters are, and it's untreatable, and there's no way to affect it. It's a protein marker on your cholesterol molecule, okay? It's a protein that affects somehow the way cholesterol works. I don't think we understand it very well. I certainly haven't figured it out from anything I can read. There's other protein molecules that we can measure, like the Apoe genotype that I test on people frequently at annual. I do this test on just about everybody that has an abnormal lipid panel, which is most of us at the time of their annual. The Apoe genotype, typically if you have copies of the non-wild type ApoE4, like me, I have one copy. It gives you a poor cholesterol panel. It quadruples your risk of Alzheimer's, dementia. We'll drill down a lot on dementia. We'll talk about it, how it occurs, and what the lifestyle modifications are that I practice diligently. I've got good cognitive scores. I don't think I'm getting any level of cognitive decline at this point at 57. But anyways, there's a lot of other protein markers I can look at that I can help use to stratify risk to decide in a little more in depth whether to put you on a statin or not. There's the CIMT, the carotid intima media thickness. We talked about this when I brought this up before. So CIMT, carotid intima media thickness. This is the media, the muscular layer. The intima, or the endothelium of the blood vessel, is here. Here's the channel with the blood cells flowing through it, and then here's the other wall of the artery. If this was the carotid artery, the CIMT would be the measurement from here to here. I have a machine that does that. We know what populations, based on age, sex, and ethnicity, what their average CIMT might look like. And we can tell you where you are compared to people your age, sex, and ethnicity. And I measure that every year, annually. My carotids are around the 50th percentile for thickness, but very smooth, and I don't have any plaques in my bulbs. I can see if people have calcified, ruptured and calcified plaques in the bulbs, which is where the more turbulent flow is, where the single vessel branches into two, the internal and external carotid. So that's something that we look at and measure and follow, and it can kind of help me risk stratify. There are tests that we can do that determine if your plaques are stable or not. So when I get a patient that maybe is in that higher risk stratification, and maybe I know they have some plaques, like they've had a calcified carotid plaque because I can see a small piece of calcium up in the bulb. Maybe a family history, we're fretting over whether or not to start a statin or try one. One of the things I can do, if they tell me I've maxed out on lifestyle, they're doing everything right, and I know they are, we can see if their plaques are stable. You know, you're 57 years old, I got some plaques somewhere, are they stable? Well, there's blood tests I can do that look for proteins that suggest that your plaques are not as likely to rupture. If those are high, they may push me to put a patient on a statin. And then we talked a little bit informally during the MESA score discussion about the coronary artery calcium score and the CT angiogram. Now, the coronary artery calcium score is a brief CAT scan, very low radiation, that looks for coronary artery calcification. The arteries of the heart, is there calcium in them? Calcium is correlated with scar in the blood vessel. It indicates that you had plaques that ruptured and calcified. So if there's a pretty high calcium score, you've probably got some blockages. Now mine was 6, and 0 to 10 is basically 0. Very little risk of atherosclerotic cardiovascular disease. I went ahead and did the angiogram as well and showed no evidence of any obstructive lesions, meaning my whole tree was open without any narrowing. As you saw, that low calcium score down classified my risk of a heart attack and stroke with my current numbers. So I'd like to get calcium scores on people that are in my age group that have some risk. I also wouldn't mind an angiogram because it's more detail, and then I can use calcium score and follow it and feel comfortable that the angiogram is reflective of the calcium score thereafter. I can get a calcium score in Las Vegas for $145 out of pocket, and you can get the combination calcium score CT angiogram for $585, and that's a strategy I'm using to investigate in greater depth the patients that I manage. So look, here's the synopsis. Cholesterol and LDL is related to cardiovascular disease, and there is a linear relationship. And there is evidence that there are less heart attacks and strokes in patients who are treated with statin therapy. Though when statins are used aggressively in a primary prevention strategy, they don't improve mortality, though they might decrease the number of cardiovascular events. But people don't seem to live longer, which means they're causing problems. There are significant side effects. I'll discuss a few of those briefly that worry me more than others. There are also benefits. Clearly, if you have unstable plaques, like you've had heart attacks and strokes, you should be on a statin. Clearly, if you have overall healthy profile besides a bad cholesterol panel, I think I'm comfortable if I can demonstrate that you have no evidence of overt disease, nothing in the carotids, nothing in the coronary arteries. I am going to be resistant to putting you on a statin, especially in the face of stable plaque testing, no elevation in inflammatory markers, ideal sugar metabolism. I'm going to be resistant to put you on a statin just because your cholesterol is between 70 and 189, and your risk prediction because of your age, sex, and ethnicity, plus whatever your blood pressure is, exceeds 7.5%. But that's usually only going to be in the context that I really think you're eating the lifestyle pill, okay? If you're going to just go with the disease model, why are you listening? I'm trying to teach you how to escape this problem. All right, what are a couple things that I want you to be aware of on the whole statin issue as far as side effects? One that bothers me is the increased risk of type 2 diabetes. It points out here and up to date that it appears likely that statin therapy confers a small increased risk of developing diabetes, and that the risk is slightly greater with intense statin therapy. Both randomized trials and observational studies suggest the beneficial effects of statins on cardiovascular events and mortality outweigh an increased risk of conferred by promoting the development of diabetes. Yeah, but if you got a lot of genes that put you at increased risk for diabetes, and so you got a bad cholesterol panel and no evidence of cardiovascular disease, are you going to take a statin? Me, probably not. It's a real thing. And again, I think that everything that we look at in medicine is looked at through the lens of the typical American, and I'm asking you not to be that person because you're supposed to get in the other line, remember? All right, what else do I worry about? Cognitive decline. Nothing much with regards to cancer, most of these other things. Some decline in androgen synthesis, but not felt to be clinically significant. Well, I can fix that anyway, so that's not a good reason to not do a statin. Above diabetes, there are some problems with liver functions that need to be followed. We follow those. There is such a thing as muscle injury. It's pretty rare. The side effects of muscle symptoms, musculoskeletal aches and such, statin-induced muscle adverse events, they say that it's mostly nocebo effect, meaning everybody knows you're supposed to have muscle symptoms when you're on statins, and since you know you're on a statin, you're going to have muscle symptoms. And that it's less probably, when they look at the placebo group versus the treatment group, the difference is not that great, though there is a difference. So there is some muscle issues, and there's actually a gene that confers that. Anyways, I don't take putting people on those drugs lightly. They affect cholesterol metabolism. Cholesterol is the parent molecule of all your hormones. I think we're a little out over our skis when it comes to some of what we do in medicine. I know that I have multiple patients in my practice that are exercising regularly, that have lost weight, that have ideal sugar metabolism, good insulin sensitivity, pretty decently controlled blood pressure. They eat healthy. They have low inflammatory markers. They're in their late 50s and have crummy cholesterol panels like mine, and I've got coronary artery calcium scores on 3 other gentlemen, a 1, a 3, and a 6, another 6. I have an individual who has a family history, also has some cause of systemic inflammation that I have not yet been able to figure out. Chronically elevated, good sugar metabolism, good blood pressure, had a period of time when he was morbidly obese in his earlier life, has some plaques in his carotids, has a similar cholesterol panel to mine. His coronary artery calcium score was high, and luckily we got an angiogram, and he did have 1 moderate blockage in one of the big arteries in the front of the heart. Not enough that he's symptomatic yet, but obviously a game changer and something that's certainly expedited his pathway to behaving with more healthful thoughtfulness. But also we're gonna have to think about a statin if we can't normalize some stuff pretty quick. Anyways, I dig deep. It's the Synogenics model. It's an integrative model. We certainly don't completely deny the disease model, pill bag, surgery. We understand conventional medicine and there's a place for it, but our role is to try to get as many people to not need conventional medicine as possible. And we're going to teach that through helping you understand how you get chronic disease, proving to you you can beat it, diet, exercise, hormone optimization, quality supplementation. I'm going to keep sharing with you guys. I think the next talk's going to be probably, I won't have access to all this amazing technological video recording that I did here. I'll be back in Cordova, but we'll talk about type 2 diabetes, and we'll talk a little bit about what are the drivers of that disease, insulin insensitivity, which leads to almost all chronic disease. Anyways, I hope you guys have enjoyed this and appreciate you sticking with me. Thanks, bye.